We'll have the next speaker, Dr. Swathi Padma. You're speaking on a rare case of acute idiopathic blind spot enlargement syndrome.
Good evening, everyone. Today I'm going to discuss about a rare case of acute idiopathic enlarged blind spot syndrome. A 21-year-old female presented with a defective vision in the lateral field of the left eye since 15 days. More specifically, she was telling about a black spot seen in the lateral field, which is associated with photopsia. She gave a history of usage of ATT elsewhere for ocular TB 8 months back. She said she was complaining about floaters at that time, for which her Montuva came positive, and she used ATT for 2 months, and again she stopped because she was intolerant to the medication. There was a history of COVID vaccination 1 month prior to the presentation. Coming to the clinical presentation, visual acuity is 6/6 N6 with -4 spear. She is a moderate myope. The color vision is normal. Intraocular pressure is within normal limits. Anterior segment is unremarkable. Coming to the fundus examination, the fundus is within normal limits except for the optic disc in the peripapillary area. There is a grayish zone seen in the peripapillary area. In the left eye, it is seen even in the right eye, but more specifically in the left eye. The OS disc color image is showing the peripapillary atrophic graying or discoloration seen in the left eye. The IR image showing the atrophied area. The optical coherence tomography image of the OD is within normal limits, whereas in the OS, there is an ellipsoid zone loss seen in the peripapillary area, which is approaching up to the macula. The OS OCT disc image shows there is a outer layer ellipsoid zone loss even seen in the nasal area also. Coming to the visual fields, the Humphrey visual field 30-2, the right eye is within normal limits, whereas the left eye showed enlarged blind spot with a mean deviation of -8.29. So based on, because she is a young myopic female with a monocular blind spot enlargement and the peripapillary outer retinal abnormalities on the OCT, we diagnosed as an acute idiopathic blind spot enlargement. We couldn't do an FFA as the patient was not willing for an invasive procedure. The most common differential diagnoses are the acute zonal occult outer retinopathy and a multiple evanescent white dot syndromes. The treatment for AIBSES remains unclear, but because we thought it might be an inflammatory, we started on a weight-adapted systemic corticosteroids and sent to rheumatologist to rule out autoimmune pathology. Patient followed up after a month, and she said she appreciated the decrease in the size of the scotoma, but was intolerant to steroids and self-stopped. She was lost to follow-up for a year. After a year, she followed up where we have done a repeat OCT, and we could see that this ellipsoid zone got regenerated after a year. This is a OCT disc showing the regeneration of the ellipsoid zone here. We have repeated the OCT, HFA. OS 30-2 visual field shows there is a decrease in the size of the blind spot in the follow-up period with a mean deviation of -3.35. Coming to the conclusion, acute idiopathic blind spot enlargement syndrome is a self-limiting occult peripapillary retinopathy first described by Fletcher et al. It presents either as an isolated finding or as an entity among the spectrum of primary inflammatory choriocapillarypathies with circumscribed loss of the outer retinal function. The etiology still remains unclear. I have already spoken about the differential diagnosis. Actually, Azure and Mutes, they are in close association with acute idiopathic blind spot enlargement syndrome. The spectral domain OCT remains the gold standard for diagnosing this. In our case, we have seen the regeneration of some part of the ellipsoid zone which corresponds to visual improvement. Thank you.
So, what is the main differential diagnosis of this disease?
Acute zonal occult outer retinopathy and multiple evanescent white dot syndromes.
So, only thing is you have to do the follow-up only.
Yes, sir, we have to follow up, and we should have done an FFA in the initial state to rule out, but we couldn't do because the patient was very apprehensive. She was not willing for an invasive procedure.
You mentioned of COVID.
Yes, sir, yes.
Vaccinations. So, you mentioned about the COVID vaccination. Do you think is there any correlation?
There were studies which say that there is a viral prodromal or a viral illness which increases the incidence of acute idiopathic blind spot enlargement. But there should be a complete restoration of the complete vision normal, or the blind spot has to completely reduce if it is because of viral prodrome. That's what I have studied in one.
Okay, right.